Good afternoon, friends. In this section of the Neurocritical Care Update, over the next 15 to 20 minutes, I will be talking to you on the intensive care management of acute ischemic stroke. How do we look at combining the available evidence with the expertise in the intensive care unit? Over the 15 to 20-minute period, let me talk on the following broad headlines of brief introduction, principles of therapy, where I will just touch upon the thrombolysis and endovascular thrombectomy part very briefly because the focus of the talk will be largely on the last part of it, which is the general principles of ICU treatment, which obviously comes post reperfusion or post revascularization. Acute ischemic stroke is the third leading cause of death and disability, and as we all know, can occur because of a thrombotic episode or an embolic episode where there is sudden loss of blood supply to an area of the brain, resulting in problems that we see post stroke. Early restoration of blood flow is the key, which could be either by thrombolysis, which is about 2 or 3 decades old, and of course in the recent past, use of endovascular thrombectomy. Now these are done either as individual therapies or as a combination, depending on the timing and the kind of vessels that are involved. How early we do has also changed or has had a paradigm shift in the last decade or so. We initially used to believe that about patients who are coming early within 3 to 4.5 hours would be considered for thrombolysis, which is now extended to 9 hours based on more recent evidence, where we do have evidence of perfusion and clinical mismatch, which suggests that there is a penumbra area which can be saved. Then you can extend the time of thrombolysis up to 9, and there seems to be substantial 9 hours. And through the analysis of multiple studies in various categories of patients or in various subgroups, including age, time, wake up stroke region, etc., we do find that there is benefit of using thrombolysis as a therapeutic strategy in patients who present up to 9 hours, provided there is a certain evidence to say that there is a perfusion clinical mismatch. Now, extending of this thrombolysis has actually benefited those patients who present with wake-up stroke. And in this systemic review, it was certainly proven that you actually have to restructure your programs of stroke thrombolysis to involve patients who come to you up to 9 hours, provided you have data to say or you have evidence to say that there is a ventilation perfusion mismatch. Endovascular thrombectomy has now become a part of standard of care. Multiple randomized trials and also pooled data has shown benefit of using thrombectomy as a standard of care along with thrombolysis or without thrombolysis if there is evidence of large vessel ischemic stroke. Pooled data shows substantial benefit in favor of intervention, and of course, even in this scenario of the use of endovascular thrombectomy, the timelines have been extended beyond the 6-hour window to up to 24 hours up to 24 hours based on multiple randomized trials. In this pooled analysis by the Aurora database, we find that there is substantial benefit in the treatment arm by an improvement in the modified ranking scale in all those patients who were subjected to the treatment arm, wherein there was definite evidence to show that there was a perfusion clinical mismatch. So the bottom line is that you have to ensure through various advanced means of imaging, you have to identify that there is a penumbra region which will benefit by a revascularization procedure, and accordingly thrombolysis can be extended up to 9 hours if there is a penumbra, or if there is a large vessel occlusion, you could consider endovascular thrombectomy up to a period of about 24 hours is what the current data favors. So to summarize, there needs to be availability for perfusion assessment of the ischemic penumbra, and to ensure that there is a mismatch, and based on that you can decide to consider extended timelines for revascularization procedure. Post that, the general principles of critical care management largely remain how you will take care of any other critically ill patients, particularly more so in a focused specialty such as a neurocritical care. So about 20% of patients with acute ischemic stroke need ICU, not all of them, but about 20%, which would be about one fifth. And the reasons for ICU admission could be multifactorial, which could be just because of the severe nature of the stroke, such as a large MCA infarct or a large stroke which is impending, sort of edema, coning, etc. For close monitoring of patients who have been either thrombolized or need to be followed up closely for blood pressure management, neurological management, or for advanced hemodynamic or neurocritical care monitoring. It could be for airway management and mechanical ventilation because of a large stroke, decreased level of consciousness, presence of bulbar dysfunction, or respiratory compromise because of a presence of a hypostatic pneumonia or an aspiration pneumonia at admission. Optimizing systemic physiology to control blood pressure, temperature, glycemic control, essentially all those vital things that we do in patients with neurocritical care. Systemic organs supports if needed, such as need for a ventilator, cardiovascular support if there is evidence of cardiovascular dysfunction, or any other organ support as and when it is needed. Or it could be because of the fact that we need to be managing the intracranial complications such as seizures presenting with status epilepticus, a malignant MCA, or post-surgical after a decompressive craniectomy. Now, the crux of this period of the immediate post-admission period, either with reperfusion or without reperfusion, is with how effectively we manage the blood pressure. 80% of these patients do present with hypertension, most likely due to a protective autoregulatory response to maximize the perfusion. And as we all know, there is, as a part of the autoregulatory mechanism, this hypertension comes as a defense mechanism. So it's very important to ensure that the balance between the perfusion of the brain is maintained in these patients with stroke, as against or versus the hemorrhagic complications which can happen with very high levels of blood, very high blood pressure levels. So the blood pressure management would be again depending on whether there has been reperfusion therapy or not. In those patients without reperfusion therapy, the blood pressure is generally told to be it is acceptable to accept a BP of about a systolic of between 200 and 220, or about 100 to 120. If it is much higher than that, we do tend to drop the blood pressure marginally by about we would tend to drop the blood pressure marginally by about one third is what we would say, and or maintain a blood pressure of about two-thirds of what was the initiation or the IC test blood pressure. However, things change when we talk about reperfusion, particularly with thrombolysis. We know that there is evidence to say that you have to maintain the blood pressure below a systolic of 185 or below 110 for about 24, or a diastolic of about 110 for about 24 hours post reperfusion. And there is good data to say that as the blood pressure increases, the modified ranking score worsens, obviously because of complications. But on the other hand, if the blood pressure drops as well, there seems to be data to say that there is damage. So it's very important to ensure that there is tight regulation of the blood pressure, to ensure that it is not too high nor is it too low to cause problems. And therefore there is in fact there is good evidence to say, as you can see in this chart, that higher the blood pressure, there seems to be more problems in terms of damage or worsening the modified ranking score. So it is very important to ensure that there is a tight regulation of the blood pressure, else you will actually find that there is problems with increasing risk of hemorrhagic complications. And if the BP is too very low, you might end up with further worsening the ischemic penumbra, or further causing more damage to the or increasing the ischemia, or worsening the stroke. So in this particular study, which was an analysis of individual patient data from 3 RCTs, it was found that a MAP of less than 70 for more than 10 minutes, or a mean arterial blood pressure greater than 90 for more than 45 minutes, both caused harm. And there was data to say that there was a harm that the number needed to treat was something like 10, where any change in either a low blood pressure or a high blood pressure, that's a MAP of less than 70 or a MAP of more than 90, would result in death of at least 1 in every 10 patients, or we could say 1 in every 10 patients, if you ensure that this tight regulation of blood pressure is maintained. So higher the blood pressure, higher the mean blood pressure, there was odds to say that there was greater evidence of damage, and use of vasopressors also seemed to be a risk factor. Now, it's difficult to say whether vasopressors themselves were harmful or it was consequent to the fact that there was associated shock. Another study, which was retrospective, which was an open label randomized trial where there were 4 centers. It was noted that a BP of about 100 to 130 systolic after a successful endovascular revascularization was as good as standard therapy, wherein the blood pressure was between 130 to 185 systolic. So it's important to ensure that normal conventional blood pressure targets are maintained and it is not too low. As you can see in this data, that a blood pressure less than 130 systolic didn't particularly look to be beneficial or beneficial. The next part would be, of course, managing the complications of stroke. And if you find that there is a worsening of the NIH score by 2 or 4 points in a period of about 24 hours, you have to certainly look for complications. And there was definite evidence to say that if there was worsening in a 24-hour period in the NIHSS score, that would mean that the mortality was worse as well. The common reasons for the worsening could be intracranial hemorrhage, malignant cerebral edema, ischemia worsening, procedure-related complications, or seizures. It is also important to see that if there is a deterioration, to look for causes outside the brain, such as metabolic causes, hypoglycemia, sepsis, etc. The most common causes of worsening in the setting of a revascularized patient is usually a malignant cerebral edema or a malignant infarct, or a malignant cerebral edema, or a hemorrhagic conversion or hemorrhage into the stroke, which would warrant an early decompressive craniectomy. There is increasing evidence or increasing benefit of use of various other non-invasive modalities, and one which is fast growing in its clinical utility because of its non-invasive nature and the fact it gives you a bedside assessment is the transcranial Doppler, which is increasingly being used in management of patients with ischemic stroke in the ICU post-reperfusion, or in any patient who is admitted for management of the early acute period of stroke. It helps us to assess the recanalization in prognostication, looking for collateral flows, detection of any intracranial stenosis, detection of microemboli, and also to have a measure of the cerebral autoregulation. The other management strategies in the ICU would include assessment of airway, or management or supporting the airway and mechanical ventilation when it is needed. Usually you would consider giving supplemental oxygen when the saturation is less than 94, and a definitive airway would be considered if there is a falling consciousness or this evidence of pooling of secretions, bulbar function, worsening respiratory failure, or many a time just for proper ICP control. Hemodynamic and cardiac monitoring and cardiac support is often many times needed, which could include need for vasopressors, frequent monitoring of the cardiac function because of associated either unconnected problems or connected cardiovascular dysfunction such as stress cardiomyopathy, to ensure that there is optimal fluid balance, and of course need for other forms of cardiovascular support. The other parts of the ICU management would be such as would be incorporated in the fast heartbeat strategy, such as glucose monitoring, very important to ensure that there is tight glucose control between 140 to 180 milligram per deciliter. Avoid hypoglycemia. Hyperglycemia is also noted to be bad, not only in this set of patients, but also, of course, in any other critically ill patient, and ensure that there is optimal nutrition. But in the urge to give nutrition, it has to be done very, very carefully to ensure that there is no complication of aspiration or such other problems. Maintaining temperature is very, very important in the neurocritically ill, particularly to ensure, because every degree rise in the temperature results in a mortality of about increase in the mortality of about 7 to 10%. Other things include maintaining hemoglobin, if need be, use of antiplatelets, use of thromboprophylaxis, preferably as in the form of pharmacological prophylaxis, if not consider a mechanical prophylaxis, early immobilization, and very important is to consider acute rehabilitation commensurate with the tolerance of the patient. There is emerging data to say that there could be benefit of early rehabilitation in many of these patients. So in short, the take home points would be that common indications for patients needing admission to ICU following an ischemic stroke would be the severity of the stroke, often for neuromonitoring, need for airway protection on airway management and mechanical ventilation, optimizing physiology in the presence of other organ system failures, and of course to manage some of the complications of or some of the intracranial complications such as hemorrhagic conversion, malignant MCA syndrome, seizures, and post-surgical management. The broad guidelines or the broad management strategies include airway ventilation, hemodynamic and cardiovascular support, and all the necessary things that you do for any conventional critical ill patients, which comes in the in the mnemonic of the fast hug bits, including glucose, nutrition, very importantly temperature management, and all the rest, including early rehabilitation and mobilization. Thank you.